Good morning, students, and today's topic is about tuberculosis. Coming to the introduction, and tuberculosis is a serious chronic pulmonary and systemic disease which is caused by Mycobacterium tuberculosis. The source of infection is from humans with active tuberculosis who release mycobacteria present in the sputum. Oropharyngeal and intestinal tuberculosis is contracted by drinking milk contaminated with Mycobacterium bovis. According to WHO, tuberculosis is estimated just to affect more than a billion cases worldwide. And the incidence is more when there is poverty, crowding, and chronic debilitating illness. It is more important to differentiate from infection with an active disease. Most of the time, it spreads as an airborne from active patient to the susceptible host. In most of the people, it is asymptomatic, though it causes fever and symptoms other like pleural effusion. Only evidence of infection is presence of fibrocalcific pulmonary nodule at the site of infection. It is the only evidence. The infection leads to hypersensitivity of Mycobacterium tuberculosis antigens, and this can be detected by Montauk's test. And this Montauk's test is done after 2 to 4 weeks after infection as an intracutaneous injection of purified protein derivative of Mycobacterium tuberculosis, which induces a visible and palpable indurations that peaks in 48 to 72 hours. And the positive test signifies the T cell mediated immunity to Mycobacterium antigens, and false negative results can occur in viral infections, sarcoidosis, malnutrition, Hodgkin lymphoma, and immunosuppression. And false positive diseases can occur due to infection with atypical Mycobacterium or any prior vaccination with BCG. And the pathogenesis of tuberculosis is the infection, primary infection. Mainly it is affecting lungs. It is seen mostly in the lungs, and in the lungs it is either affecting lower part of upper lobe or upper part of lower lobe. So here the infection will be seen in the upper lobe, the lower part, and the affected part undergone caseation. If the organism is drained into the sentinel lymph nodes, and there will be caseation in this lymph node too. And this caseation in the lung parenchyma is called Gons foci. With this combination of caseation in lymph node, it is called as Gons complex. It will go in different pathways. If the lesion is healed, the affected tissue undergo fibrosis, and it will be seen as a scar in the lung parenchyma along with scar in the lymph node region. In here, it is the organisms are viable or not viable. If the primary complex is going into latent period, and here the organisms are dormant in pulmonary or extrapulmonary sites. If in these latent lesions, if it is reactivated, it is progressed into secondary tuberculosis. In the case of this reinfection, there will be caseation along with scars and cavitation of destruction of lung parenchyma, and also with extrapulmonary lesions. It is going into progressive secondary TB and finally leading into miliary tuberculosis through hematogenous dissemination. If the primary complex is progressed into progressive pulmonary TB, and here it may be finally leading into miliary tuberculosis through hematogenous dissemination. Dissemination is nothing but spread. The organisms spread throughout the body via blood vessels through hematogenous route. In the miliary tuberculosis, they will be affecting the mostly liver and spleen. It is showing gravid lesions in the organs as seen in this pic. This is the main natural history and spectrum of tuberculosis. and the main pathogenesis, how the organism is entering and causing the symptoms. We will see now. The first, the mycobacterium is a bacilli, all we know here. As we already know that these bacilli enters into alveolar macrophage with the help of mannose 3 receptor or mannose C3b receptors. With this entry, it forms a vesicle around it, so that it is inhibited from lysosomal action of these macrophages. After formation of a vesicle around the microbe, there is manipulation leading into maturation arrest, lack of acidic pH, and ineffective phagolysosome formation. If it is unchecked, there is proliferation of bacteria within this vesicle. If it is spread through multiple sites, it is called as bacteremia. Bacteremia is nothing but blood loaded with bacteria. This is the case of unchecked cases. If it is activated or checked with interleukin 12 and T helper cells, with the help of these T helper cells, there is antibodies produced against this bacteremia with the help of interferon gamma, which is produced through T helper cells. The macrophage gets activated. With this activation, there is phagolysosome maturation and activation and production of nitric oxide and production of reactive oxygen species and autophagy. With these phases events, there is mycobacterial killing, and this Th1 will be seen as a tuberculin positivity in case of Montague's test. With this autophagy, it is seen as central necrosis, which is surrounded by epithelioid histiocytes, and these epithelioid histiocytes are nothing but activated macrophages, and the lymphocytes are recruited to this area, and this classical granuloma formation occurs in case of Mycobacterium tuberculosis. This is the main pathogenesis of Mycobacterium tuberculosis. So we will see the morphology. First, primary tuberculosis. It is almost always begins in the lungs. An inhaled bacilli implants into either upper part of lower lobe or lower part of upper lobe. As the sensitization develops, 1 to 1.5 centimeters area of gravate inflammation with consolidation develops. It is called as Gons focus. After it drains into the regional lymph nodes. This combination of pulmonary lung lesion along with nodal involvement, it is called as Gons complex. Lymphatic and hematogenous spread occurs through other parts of the body. And this Gons complex undergoes progressive fibrosis, which is followed by radiologically detectable calcification, which is called Ranke's complex. Microscopically shows granulomatous inflammation that forms caseating and non-caseating tubercles. And these granulomas are enclosed within a fibroblastic rim, which is punctuated by lymphocytes. And the multinuclear giant cells are seen within the granulomas. Immunocompromised patients do not form any granulomas, as their macrophages are loaded with bacilli due to in these immunocompromised patients do not form any granulomas, so that their macrophages are loaded with many bacilli. This is a gross pic of primary pulmonary tuberculosis showing grey white area in lung parenchyma. It is the Gons foci. This is the sentinel lymph node showing necrosis. It is the caseation necrosis of lymph node, and this combination is called Gons complex. And the microscope is showing in low power is showing central necrosis, which is surrounded by multinuclear giant cells and epithelioid histiocytes. In the high power, we will see here central necrosis, which is surrounded by multinuclear giant cells, and here is all the epithelioid histiocytes and recruitment of lymphocytes occurs. This is a microscopy in immunocompromised patients, they do not form any granulomas, so that these macrophages gets filled with bacilli. This is a pic showing acid fast stain. Macrophages are filled with or packed with mycobacteria. This is in case of immunocompromised patients like AIDS patients. And second, the secondary tuberculosis. The initial lung lesion is small, focus of consolidation. They are firm and gray white in color with central caseation and fibrosis. They undergo fibrous encapsulation, forming fibrocalcific scars. And these active lesions show coalescent tubercles with central caseation. The localized, apical, secondary and pulmonary tuberculosis may heal by fibrosis either spontaneously or they can heal by after therapy. And the disease progress and extending into several different pathways. This is the secondary pulmonary tuberculosis showing localized destruction of lung parenchyma, the formation of cavities along with caseation and necrosis. Softening of lung parenchyma is will be seen here. And the next type is progressive pulmonary tuberculosis, which is seen in older patients along with immunocompromised patients. In these, the lesion expands into the adjacent lung and erodes bronchi and blood vessels. And this expansion leads to excessive caseation and forms irregular cavitations. And the expansion of blood vessels leads to hemoptysis. With the proper treatment, there is arrest and heals by fibrosis and distorts pulmonary architecture. If the host immune system is impaired or without any inadequate treatment, this infection spreads via lymphatics or through blood vessels. And the next type is miliary pulmonary disease. In this, the organism drains through the lymphatics and enters the venous blood and circulates back into the lung. In the lung, these individual lesions are either microscopic or small and may be visible foci of yellow-white consolidation scattered throughout the lung parenchyma. And these lesions may expand and coalesce, resulting in consolidation of larger regions. Pleural effusions, tuberculous empyema, and obliterative fibrous pleuritis may develop in these patients. This is a miliary tuberculosis of spleen showing many gray-white tubercles. And the next type is endobronchial, endotracheal, and laryngeal tuberculosis, which may develop as the organism spread through lymphatic channels. In this, the microscopy shows the mucosa which is studded with minute granulomatous lesions that may be seen only microscopically. And the next type is systemic miliary tuberculosis, which is occurred when the infection enters systemic arterial system, which is more prominent in liver, bone marrow, spleen, adrenals, meninges, kidneys, fallopian tubes, and epididymis, but it could involve any other organ. The next type is isolated tuberculosis. As I said earlier, this TB can occur in any organ, which is seeded through mainly hematogenously. If the organism involves a meninges, it is called tuberculous meningitis. If it is involving kidney, it is called renal tuberculosis. If it occurs in vertebrae, it is called Pott's disease. If it infects the adrenals, it is the most common cause of Addison's disease. If it occurs bones, it is the most common cause of myelitis. If it spreads to the fallopian tubes, it is called tuberculous salpingitis, or it can cause cold abscess, which is paraspinal, which may be present as a abdominal or pelvic mass, and lymphadenitis, which is the most frequent presentation of extrapulmonary tuberculosis. And this lymphadenitis in case of HIV, how it is present, you will see here. In HIV negative patients, this lymphadenitis, which is unifocal and localized. In positive patients, it is always multifocal. And intestinal tuberculosis, which may be caused due to drinking of contaminated milk with Mycobacterium bovis, which can be prevented by pasteurization of milk. And these organisms seeded into the mucosal lymphoid aggregates are small and large bowels, and they undergo granulomatous inflammation leading to ulcer of underlying mucosa in the ileum and the healing of these ulcers causing strictures. And the last is Mycobacterium avium complex, which is common in soil, water, domestic animals. It is a clinically significant infection which is associated with HIV and immunosuppression and leads to treatment for transplant rejection or autoimmune disease. This is acid fast stain of immunocompromised patients showing acid fast bacilli. And that's the end of the class. Thank you.